So when thinking about TFR monitoring imatinib, I came with this question: what is the best way for treatment, and for a country with low resources? So Sue mentioned already her study in this letter to the editor published at Blood in 2019, and what next? What she just told us that no, yeah, that is one test every 2 months in the 6 first months, then a test every 3 months from month 6 to 12. And what's very interesting about the study was also that when you lose the molecular response 4.5, you return to a monthly test. And this is something that we would keep in mind in our country. And then there is this nice comment by Dr. Lipton saying that is still room to do less and much less, in other words. And he is suggesting that comment that we need to do a real world study with those number of tests in a minus number of tests. Next. So what I would like to present in a very fast way, was a study conducted by Dr. Centroni and colleagues. It's the DEEP study. It was a first-line treatment discontinuation project, and this study was paid by Hemomed, is a hematologic clinic. Here are the characteristics of the patients over 18 years, all CML chronic phase, all of them at least a molecular response 4 or 4.5, minimal treatment time 5 years. They have a minimum 2 years of a sustained molecular response of 4.0, 4.5. We are not going to discuss the primary endpoint because this is not the reason for presenting that study. And what I would like to show is the secondary endpoints, the analysis of the economic viability of the cost of the test based on the results of discontinuation. Next. So 26 eligible patients, 20 agreed to participate. 60% of those were in a molecular response 4.0, 40% in 4.5. The median age 54.4 years, the median follow-up 36 months, and the median treatment time 8 years. Next. 60% of the patient persist in TFR with a 36 months of follow-up. The median time of loss of major molecular response was 7.2 months. That is very similar to what the literature shows, that's around 6 months. 100% of the patients have already achieved a major molecular response with the reintroduction of imatinib, and the median time of the getting back a major molecular response was 5.2 months. One patient was excluded for failure to adhere. As I told you, adherence is very important for TFR. One died of COVID still with molecular response, 4.5, and one patient had delay of recovery due to lack of medication. This is something that is not very rare to happen here in Brazil, even if in the private system. Next. So just to make it very quick, those were the prices of Gleevec and imatinib for a treatment of 400 milligrams a day, and the market value of the qPCR, $222. The number of qPCR performed was 324, and we used what was at the beginning determined was that the PCR test was monthly for the first year. We were more stringent with this, not for only for 6 months, but for the first year, bi-monthly from 12 to 18 months, and then quarterly, so on. As I told you, EMOMED paid everything, the exams and medications. Next. So I'm going here to show you that the savings with the discontinuation of treatment was $861,000 in Gleevec, $641,000 in imatinib copies, with this median follow-up of 36 months. And this saving would allow us to pay for more 2,300 qPCR exams. So the data presented here, we presented the data to the health providers, and they did not feel very convincing without all those savings. And one of the reasons that we thought is what they were more concerned about paying more exams for the patients in TFR and not thinking about what they would save not buying the medication. Next. So I'm coming up with this question: would it be possible to transfer this data that I just show to the public health system, knowing that how is the public health systems? And next, and for the public health system, no discontinuation is a better solution.
Letícia, vem. Vamos, Fabi.
So asking those questions, we might go across to our experts and perhaps start this time with Sue.
Yeah, I think that's unfortunate that the government wouldn't take those very strong financial statements. And I believe that sometimes there might be different groups that actually pay for the drug, and then there are different groups that pay for the funding of the testing. And so that may be the issue, that one group may think this is a perfectly reasonable, but then the other group is going to have to pay more for the funding. So I don't know whether that's one of the issues. And of course, I think continuing to lobby the financial institutions who are paying to hopefully make them see some sense and some benefits of stopping therapy and then the financial savings. So maybe you just need to get different groups within the government to talk to each other.
Dennis, would this happen in Canada?
Yeah, it happened in Canada, but now it has become a little bit better. It's basically because of the kind of bureaucracy issues. So the money comes from the different pocket. The PCR testing comes from the diagnostic budget, and the medication comes from the different pocket. That makes that kind of issues. But now we also pushed our government a lot, and now they have a better understanding. And now they are funding for the molecular testing, and now we don't have that kind of limitation of a monthly testing. However, I think that another good way to tackle this issue is that maybe as a group, rather than just a single person to talk to your government, maybe as a group, you may have to come up with some guideline or recommendation. If you just bring the international guideline, they say that, oh, it is international, it doesn't apply to our current situation. then you can come up with your maybe a Brazilian or the Argentine guideline, and you can show it to your government, and you can clearly state a kind of sentence saying that there is a pharmacoeconomic superiority of this approach over the non-TFR approach. Then they will start to understand that. Thank you.
And looking at the situation through Argentinian eyes, Isabel.
Well, in Argentina, the Argentine Society of Hematology makes great efforts in order to achieve or to reach the idea of the TFR patients, for patients with CML. With no doubt, there are many benefits in the TFR group, but always thinking if those patients are well treated before the TFR period. Our public system is not perfect, and the TKIs sometimes are copies, not branded, and sometimes the patients are not so well adherent to the treatment, so they don't reach the TFR possibility. But those who enter in the TFR regimen are well monitored site, and it has a good benefit to the health system for saving money and all the financial support of the TKIs. We have a good system to monitor those patients in all of the country, with financial support of the industry, with vouchers, with agreements with the government health systems. So this aspect is something well covered.
Thank you. Some good reflections there. Now, we still have lots of material to get through, so I'll move us on, please. Sorry to rush us on, but Israel, can you keep going, please?
Where I am. So, how important? Okay. So, this is something that concerns me a lot here in Brazil, because there are many labs that are doing real-time PCR, and this is one of the questions that I always made to myself, is how important to have a stable conversion factor for monitoring CML patients. This is not because I don't believe. I believe that you should have a conversion factor, but it's not what we see around the country where this test is performed. So, and the other question is, does it matter which control gene in monitoring CML patients? In my lab, we are using BCR, as we learn since our visit to Adelaide, but many other labs, I think almost all of the other labs, are using AB1, because it's kind of very rare to be used as a control gene. And then how important is to mention the number of copies and the number of copies and which control gene was used to test and to report the results. So this is, I would like to just to know Sue's and Dr. Giere opinion.
Dennis, would you like to start?
Yeah, so I think that our lab, we use a PCR, but I think that whether you use PCR ABL1 or GUS, it is not a in my knowledge, it is not a big issue. Whether you already have some very solid conversion factor, then just utilizing it, you just continue to monitor them. But don't change. You may not want to change the reference gene in order to provide that kind of stable monitoring. Then you just continue to use your current control gene for your qPCR testing. I'm pretty sure that Susan also has the same idea. Thank you.
Yes, I agree. I think what's really important is the sensitivity that you can achieve with individual RNA samples. So at the control gene level is actually an indication of how sensitive that sample is and the degree of degradation. So you mentioned that it can take up to 48 hours to get the sample to the lab. So that's what's important, is indicating whether the sample is a good quality sample. If it's a poor quality sample and BCR-ABL is undetectable, then you have to interpret that the patient may actually be relapsing. So further testing is required and trying to get the sample off to the lab as soon as possible.
But in your opinion, what do you think about not mention in the report what the control gene was used and the number of copies of this control gene?
Yeah, so we don't actually report the number of copies because we're using BCR. So that is actually quite irrelevant. The really only relevance is if you're using ABL, because there has been publications showing the importance of various levels of control gene. So I think if you don't report the level of control gene, that's okay, as long as you give some indication of the sensitivity. So what we do is say that this sample has achieved a sensitivity of MR 4.5 or MR 4.
Okay.
Thank you, experts. We are really running behind time, so I am going to push us on a little bit, please. Isabel, if you have comments, hold them over until your presentation, please. Sorry to move us on, but we're a bit behind.
Well, in this point,
Isabel, would you mind holding over your comment until we get to your presentation? So we might just move on to the laboratory setup, but we will get your comment later. It's just I'm getting very worried about time here, please.
Okay, I understand.
Okay, next.
Okay.
So just for the lab, next, please. So to the BCR-ABL testing laboratory setup, we are taking very in consideration the sample collection and preparation. We are using asking for 4 tubes in EDTA, and we stabilize the sample in Trizol. The control gene and the assay sensibility, we at least 4 log reduction, and we use the international scale to report the data. Next. Next. So the assay procedure involves several steps. I'm not going to talk about this. And also it's important, the calibration and the quality control and validation. We should use a low and a high level of BCR-ABL1, negative control. and a reference panel validated by the WHO. But in our lab, we are using a calibration curve made of plasmids. Next. The last discussion. How important are duplicates for each sample to be performed? And could GeneXpert system replace the regular RT-qPCR?
Isabel, I'm so sorry for moving on the last time. We might start with you this time.
Yes, it's important to make duplicates in each sample in each assay because of the to check the changes in handmade cake. And GeneXpert, it's an interesting platform for those labs, for those laboratories that cannot set up the RT-qPCR, the traditional one, the recommended one. And it's a good platform to have the diagnosis and the monitoring during the first year till the patient reaches the MMR or MR3 and so on, because now there are platforms of GeneXpert systems more sensitive, and well, that those work well. Okay.
Sue, would you like to comment?
Yes, I certainly agree. We do everything in duplicate because it reduces the variability. So when we're looking at very low levels of BCR-ABL, this means that we can see more precise results. In terms of the GeneXpert, there was a question in the chat about can we use for monitoring for P190? And I think this is an important question because not only can the GeneXpert be used for the P210 BCR-ABL, but now there are P190 cartridges available. So this may be applicable for monitoring patients with the P190 that are rare in CML, but it could be applicable for AL patients.
Thank you. I might move on to Dennis, but can I ask other audience members, please, if you aren't actually wanting to be heard, could you please keep yourself on mute? Dennis, what are your thoughts?
Yeah, I agree with Susan. I think that GeneXpert teachable system, and it will be really good for the hospital having a small number of the volume of the PCR sample, but it also has a limitation. We also have to recognize that. Thank you.
Israel.
This is what I wanted to hear.
So experts, any further reflections on this before we might move on to Isabel's presentation? Okay, well, I'm glad, Israel, that you heard what you wanted to hear at the end of your presentation there. Thank you so much, Professor Israel Bendit, for sharing your wisdom and the Brazilian experience with us. Thank you, Professor Sue Branford, Dr. Dennis Kim, and Dr. Isabel Giere for your insights, and also the audience. We will move on to the second part of our discussion, when and how to look for BCR-ABL